Welcome to A New Prescription, where we explore modern healthcare, cutting-edge medical research and technology, and the complexities of healthcare politics. Join us as we provide insights and solutions to help you navigate the American healthcare system.
Hi, everyone. Welcome to another episode of A New Prescription. This is Len Zwelling. I'm here with my son, Andrew, and we have the most special guest because this is someone I have known for over 50 years. He was my teacher, my rounding man, when I first went to the National Cancer Institute to become a medical oncologist. Since then, we've become very close friends. He is an internist, an endocrinologist, a medical oncologist, and one of the foremost experts in breast cancer in the world. He was my attending, my running partner, my tennis partner, my golf partner. We've published together. This is Dr. Mark Lipman from Georgetown University and the Georgetown Cancer Center. And the topic today really was one that Mark decided we were going to talk about, which was how has our generation, Mark's and mine, left medicine? Is it better or worse than when we found it? So, Mark, let's get started. What do you think the most important thing that has happened to medicine in the past 50 years from the doctor's perspective?
Well, that's a terrific question. First of all, thank you for the kind words that you shared with me. In my mind, what's the biggest change from a physician's point of view are two things. One, a very wonderful thing, and another thing, in my opinion, rather terrible. The wonderful thing is that in our last 50 years of practicing medicine, we have seen a growth of technology and skills and diagnostic potential and instrumentation that's just unfathomably fabulous. I can't imagine almost anything I did except being with patients 50 years ago that isn't radically different now. And I think that's wonderful. I think that there are certain kinds of issues and problems that people face that you really don't care if you have the most impersonal, unfeeling automaton as a physician. You just want the right pill, you want the right robotic surgery, and you don't need to even see the person. Literally, robotic surgery can be done at a distance. Unfortunately, in my view, particularly as it certainly applies to more chronic diseases, cancer, heart disease, all kinds of geriatric frailty issues, what's changed, which I think is really very regrettable, is that everywhere you look, patients don't know who their doctor is. They don't have a doctor. They can't call somebody. They can't see somebody. They can't find someone who's going to put their hands on them, look in the eye, and understand their entire context of what's bothering them and try to interact. And I passionately believe that those interactions have everything in the world to do with people having high quality life and high quality interactions with the medical profession. And I think we've given it away. I think we've given it away, and I think we're going to great lengths to train it out of our young people. And I regret that.
Well, let's start with the first thing. To whom have we given it if we've given it away? Because I agree with you, of course.
Well, I think that's once again a terrific question. I think that when we talk about to whom we've given it, for one thing, physicians gave up the notion, in my mind, and this is an oversimplification. I'm not saying everybody, I'm not saying all circumstances, but we've given up the notion of it is a profession, something we do because we are motivated to do good things. Physicians became businessmen. They started developing companies for dialysis, for outpatient surgery, for all kinds of things in which they could make money. And then it turned around and bit them. 30 years ago, most physicians were either in private practice or in practice with 2 or 3 or 4 other people, small groups of people who knew each other, covered for each other, knew their various patients. And then physicians, because of the huge reality that most of the money is on what's called the technical side, realized that what they did as E&M codes, seeing, touching, was basically a path to starvation. So they needed to acquire, so they thought, all kinds of technologies in their office, their own infusion centers, their own radiology suites. and try to do that in order to be able to bill and make money. And hospitals made, not forced, but encouraged, and physicians basically, in my opinion, uh, led themselves to the gallows, decided to be bought, became employees of
Yes.
large combines in which expectations had little to do, as best as I can tell, with happiness and satisfaction. And it's led to patients being, I think, far more hostile than they were to physicians in the old days, and physicians being far more hostile to the medical profession, to their colleagues, and to the institutions with which they work. And I think this all filters down to a often very regimented, very short, and often very inadequate interaction with patients, where the rubber meets the road.
Do
Most
you,
physicians,
did this,
go ahead, you talk.
did this contribute to the burnout that we hear so much about in docs?
I'm certain it does. I'm absolutely certain it does. I think that many physicians commonly complain they don't have enough time. They're inundated with a variety of irrelevant tasks, computer-based learning, documentation, all kinds of things that really have little to do with the time that they spend with patients. In some sense, while there are certainly great advantages to the electronic medical record, this has become a disease. Most of my young trainees, they sit there facing a computer when the patient is sitting in the room with them. They're not making eye contact. They're looking at a screen. They're typing in answers. They're putting in, and there's no touching. I am struck endlessly by the inability of the physicians with whom I work, and many of them are very bright and highly motivated, their inability to exact worthwhile clinical information from patients, either by physical exam or by history taking.
Okay, we talked about this when we were preparing for this. I'd like you to tell the story about how you discover they don't know how to do histories and physicals when you teach them, because you're still an active teacher and investigator. So that was a really good story of how you figured this
I
out.
don't recall the one you mean, but if you've
Or
done,
you go in and watch them do what
oh, it's absolutely the case. We have at Georgetown two attending system. We have a hospitalist, which in my opinion is a horrible invention. And we also have teaching attendings. So when I do that, I have no responsibility for billing or for any serious authority. I'm just there to teach trainees and medical students. And the last time I did this, I said to each of the three third-year medical students, I think I'm going to sit in a room and watch you do a history and physical. I'm not going to say a word to you. Just go in there. This is the first time you're seeing the patient. Do what you do, and then we'll talk about it afterwards. And these aren't just the first time they're seeing patients, and they're inept. They don't know how to do physical. They don't know how to listen to a heart. None of them can look at a fundus. They really don't even know how to examine lungs very well. And most of them are just regurgitating what's seen in the electronic record that's been written by somebody before them. I saw a patient about a month ago, a woman with well-controlled breast cancer, status post-adjuvant endocrine therapy, doing really quite well. But she has problems with blood pressure and blood pressure control, and she has diabetes. And so as part of my talking to her about how to deal with this, I thought I would just take a look at her fundi, because that's a real mirror into her vascular status.
Before we go on, that's looking into the back of the eye. We have people that aren't doctors that listen to our podcast.
Correct. It's a way in which you can see the blood vessels arrayed on the back of the eye on top of the retina, and you can see what their status is. And so I look at her right eye, and it looks pretty good. And I start to look at her left eye, and I can't see it. I just see something dark. And I step back for a second and look again. And I say, "You have a glass eye?" And she says, "Yes, I do." Well, that's perfectly okay. But then when I look at the chart, the last, about 16 or 20 notes going back for a year and a half are all PERLA, which means pupils equal, round, regular, reactive to light and accommodation. And no one has possibly done that. No one has possibly done that, because you can't make a glass eye do anything except be a paperweight. And I just feel that nobody notices and nobody cares about these kinds of things. I think that most of the trainees that I work with do not know how to listen. They don't know how to sit there and just say, tell me what's going on with you. How are you? How do you feel? And when you start to do this correctly, patients relax, they feel comfortable, they tell you what's on their mind, and they feel better. They enjoy the interaction. And it's very unusual that physicians don't enjoy that interaction as well. They just say, I don't have time. I can't do it. No, I've got to see patients every 10 minutes. And you just cannot take care of people in that kind of window. Maybe if you're dealing with a hangnail, you could do that. That sort of focused exam. You don't need much else. But for people with illnesses, my goodness, my goodness. And
Yeah, I've always said when I've had this kind of discussion about the patient every 15 minutes, I could not imagine getting through my clinic at the National Cancer Institute with a patient every 15 minutes. If I had 10 patients to see that day, somebody was going to have a serious problem that needed attention that wasn't, couldn't be handled in 15 minutes.
well, of course you're right. And other aspects of this, I think, are equally harmful. When I went into medicine, when you went into medicine, if you were working as part of a medical center, if your patient got sick, you saw them in the hospital, you looked after them. And everybody said, well, taking care of patients in the hospital is so technical. We need a new specialty called hospitalists. Well, the theory might be sensible, but the practice is horrible. Hospitalists work shifts. They hand people off like cafeteria trays. They don't really know who the patient is. They're paid by the patient. They're not paid for any outcome variables particularly. And the physician who's been looking after this patient perhaps for years is kind of removed from the situation unless they proactively decide to go see their own patients in the hospital, which is basically unheard of these days. So
Well,
you transfer the patient.
it happened to me when I had a hernia repair and was walking down the hall at 11:30 at night because who can sleep in a hospital? And I had this incredible sense of dread and a little shortness of breath. And I crawled myself back to the bed, called the nurse and said, I've had a pulmonary embolus. And the called the hospitalist, of course. And fortunately, I talked him into starting heparin, starting the anticoagulant. Nobody believed I was right. Of course, the scan the following morning showed I was exactly right. And I had indeed had a pulmonary embolus when my attending came in to visit me because they called him. It is scary when a hospitalist comes in your room when you have a problem, if you're the patient.
I agree with that. And it's not, and it sounds like I'm picking on them because I think that's not a fair thing to do. I think many of them want to do the best job they can. But if they've got a panel of 20 patients in the hospital, they're putting out fires. They're not going to sit there and say to the family member, this is what I think's going on here. They're hoping to get out of their shift and be done. And I think that's
So I
very
guess
unfortunate.
before we get to the patient's point of view, I want to ask you what I think is a $64 question, which is why did we let this happen? What did we as physicians do wrong that allowed our lives and our profession to be devalued by society?
Well, that is the right question to ask. Um, and I don't know that I'm personally equipped to be the source of all information about this, but I think
But
that one of
you've
the things,
been in
but
many different places.
I think a great deal of it has to do with the um, formal businessification of medicine. I mean, when I trained, physicians gave other physicians professional courtesy. What does that mean? Professional courtesy means you don't charge somebody when you take care of some doctor's family. Now, that may be outmoded. I'm not suggesting we bring that back. But there was a notion that you just did the right thing because it was the right thing to do. Now you have pre-certification. You can't even do what you want. You can't even do what you want. If I say to somebody, if I act promptly on occasion, the patient will be left with a bigger bill because I somehow didn't get some who knows who to certify and agree with this. It's very, very unfortunate. But I think that the main reason here is that the money has become aggregated in hospitals. They do live on very, very narrow margins. They sell thousands and thousands and thousands of tasks with minimal profit. It's like a supermarket. And so they become extremely focused on throughput, on efficiency, and very little on the kinds of things that I believe really are necessary for human beings when they don't feel well to be supported and cared for by somebody who knows who they are, knows what's going on with them, and takes responsibility. There's almost never a captain of a ship anymore. When a patient's in a hospital, you say, who's in charge of this case?
Patient doesn't know.
Nurse doesn't know. Patient doesn't know. Nobody knows.
So let's go to the patient's point of view over the past 50 years. You touched briefly on the benefits of new technology, new imaging, also new pharmaceuticals. There's a new cancer drug almost every week in the New England Journal of Medicine. It's really, I don't know, it's startling. I don't know how you keep up. I'm sure you keep up in breast cancer, but even that is pretty amazing how quickly that's progressing. But what's the downside for the patient? You sort of hinted at it. The doctor-patient relationship has been severely damaged, it sounds like.
Well, I think it has. And I think that there are lots of things that happen that are bad. I think that one, patients are unhappy. They don't know what's happening to them. They don't know who's doing what, and they're frustrated, and it makes them angry. It makes them non-compliant with what really is in their best interest. Those are obvious outcomes for many diseases, not just cancer, but very well documented issues in which things that are called things like social support and relational issues make a big difference in survival and outcomes. And physicians are the leaders of the team in this, and they've just walked away from it. I mean, it was so common in the last few years that when a patient comes in, the first thing people order are 6 consults. You know, someone comes in short of breath. Oh, let's get a cardiology consult, a pulmonary consult, and a renal consult. So you have a bunch of people coming by, poking for a little while, and the patient's left completely at sea because no one collates this and the hospitalist isn't going to do that. The hospitalist is there for 12 hours and then gone. And I just think that this winds up, it makes me super grateful that my wife is a physician so that if and when I get stuck in a hospital, I'm going to have an advocate there to look out
Yes,
for me.
I too am married to a physician, and I couldn't echo that more clearly. You have the best advocate for you when you need it, and vice versa. But I guess the other thing is, aren't patients having far more trouble getting into systems to even get started with a doctor? I mean, I don't know about you, but I get called. Jeannie and I probably have a call a month to get someone the cancer care they
Of course.
need.
Of course. I mean, and what's even more reprehensible, Georgetown, though the hospital is owned by MedStar, Georgetown is a Jesuit institution with the cura personalis, the whole notion of taking care of the entire individual. It's a moral institution. But I have had more than one patient who, because they moved, for example, from the District of Columbia across the river to Virginia, for whatever reason, their insurance changed. And I was told, well, you can't take care of this patient anymore. The patient is literally evicted. We're not talking about somebody who can't even get in for the first time because they don't have insurance. We're talking about someone with whom you've established a relationship. They rely on you and they trust you. When I see my patients, I don't say this boastfully, I say this as a statement of reality. Every time I see a patient for the first time, at some point during that interview, I will say the exact same sentences. Here is my card. Here is my email. If you try to call and get into a phone tree, you're not as smart as I think you are. If you want to reach me, you send me an email. And if you don't hear from me that day, there's only 2 possibilities. I didn't get it or I'm dead. And and when I say that to patients, they invariably smile and you see their body language relax. They're saying, and sometimes they test it right away, but they're saying, someone I can reach out to when I'm sitting there and I don't know what's going to happen. And
Is
and
is
that
that
gives me
the basis for concierge doctors, you think, that kind of relationship? It
I think
becomes
that's a good thing. I think concierge medicine, at least in theory, is, and I think it's come to be because people want to have access to their physician.
Yes. Yeah,
And
I mean, we did it. Both my wife and myself have gotten concierge doctors in both cases because our other doctors retired. It happens, but um,
but there's even data, and I believe one of the concierge companies was going to do this as a study. I'm on very thin ice here. But what they said was they weren't just going to do paying customers. Okay, you can afford whatever the fee is to hire a concierge physician. But what they said was, in fact, if somebody has a doctor and someone's managing their blood pressure, someone's managing their hemoglobin A1C, someone's managing their seizure disorder, they're going to use much less medical care. It's economically sound. So they started a program where they were going to randomize. I don't know what came of it. This was, I believe, in Baltimore. They were going to randomize people on Medicaid to concierge care or not, and pay for them. The notion being that people, if they had doctors, they would stop showing up in emergency rooms just for no apparent reason. And I wish I could tell you what happened to that, but my intuition is that this would work, that this would be a solution that would actually be cost effective. I think I mean, another way to look at it, which makes my point. If I ask you, as a very experienced physician, to list 15 subspecialties in internal medicine. You say, sure, ID and rheumatology and endocrinology and cardiology and pulmonary and all these other things. And I said to you, which one is most profitable to the hospital if they employ them? I dare you to get it right.
which subspecialty in internal medicine is most profitable?
To a hospital. Yeah.
I would have said cardiology, but
Of course you
obviously,
would have. And you might have said oncology. Of course you would have. They're very reasonable choices, but you're wrong. And when I tell you what it is, you're not going to believe it. The one that is the most profitable to the hospital by far is a geriatrician. Why? Because a geriatrician doesn't get paid very much, so they're cheaper. But the same E&M code that applies to a geriatrician is to a cardiologist who's making 4 times as much. But the geriatrician, 100% of their patients over the next couple of years are going to need orthopedics, ophthalmology, audiometry, cardiovascular, cancer. So it's a referral system. So paying geriatricians to take good care of patients is a gigantically successful venture, which isn't the way it's been thought of economically.
not at
And
all.
but they are put. But when I mean, it makes no sense when you first think of it. When you have a elderly person on polypharmacy who's a little slow walking and maybe a little slow talking and takes time to get off the examining table, trying to deal with someone like that in 10 minutes is insane. It's abusive. It's insane. A veterinarian wouldn't even do that. But the fact is that actually, if you rewarded that kind of behavior, you'd have happy patients. They'd be using less services, and you'd still be more profitable for your institution.
In the end, I mean, well, first off, is the horse out of the barn? Is there any way we can gain anything about being part of a guild, being part of a profession, which was so rewarding? It was everything when we were young. I mean, that
Yes.
was everything.
Well, I think that there are several aspects of that. And once again, I'm not an authority, I'm just an opinionated person. But I think that one thing that's worth saying is it's not clear that every way in which we've done medicine has always been for the best. It may well be. It may well be that people like radiologists get replaced by machines. It may well be,
Oh,
by
yes.
AI. So it may well be that pathologists become a thing of the past. Oh, there's a little buttock cell or a little curved cell, a little bluish. That kind of stuff may just go by the board. And we have to accept appropriately and with great curiosity the need that science can do, and perhaps, and it's also the case that if you are going to have certain kinds of things done, like you're going to have a cataract operation, you're not looking for a long-term interaction. You're going to a doctor, you want him to be really clean, know what he's doing, do it in an outpatient department, and if you never see him again, probably it's better.
Right.
So I think that needs to be kept in mind. But for things that need to be managed as diseases, that have some chronicity to it, cancer, heart disease, frailty, the main things that are going to take most grown-ups off the table at some point, I think that those things need to be put back in the barn. I know that because I was at two institutions, chair of medicine, and I
Yes.
had hundreds and hundreds of medical students and residents evaluating me over the years. It became almost a joke because my recommendations, I'm talking about an N of easily 1,000. We're not talking about just two or three people who are opinionated. And my evaluations would always be the same. About 7, 8, 10% of the trainees, learners interacting with me would write out at some detail, I hope I never see him again. I hope I never see him again. A hard ass. He was mean. He was demanding. He was not very nice to me. I felt like this was worthless. And a fair number of the other 90% said it was the best interaction I ever had. He told me something, and I changed how I was as a doctor. Let me give you an example. I do all my teaching rounds at the bedside. It's gone. It's gone. And I recall very recently saying to one of my trainees, I said, well, you think the patient's hyperthyroid? Because obviously thyroid disease complicates breast cancer very commonly, and it's a very common disease, particularly in women. And the trainee said, oh, I'll get a TSH, which is a sort of answer. And I didn't say meanly. I said, well, but I didn't ask you what you would get. I asked you, is the patient hyperthyroid? And they said, oh, I'll get a TSH. I said, okay, I'll give you one more try. I didn't ask you what test you'd order. I said, then I said, let me make it easy for you. Can you be hyperthyroid with a low TSH? And can you be hyperthyroid with a high TSH? And the answer is obviously yes.
Mhm.
And suddenly sometimes a light bulb goes on that you need to have some context of what you're doing to get it right. Because at any rate, I think that I'm still answering your question. Is it fixable? Yes, I think that things can be made better by understanding what it means to be a physician and as compared to what it is to be a businessman.
Do the medical schools with which you've been associated, and there have been a number, share your viewpoint? I mean, it seems to me that's where it's going to happen. If it's going to happen, it's going to be getting the students trained differently than they're training them now.
That's once again, a terrific question. So I'm a member of a society, a medical society called the American Clinical and Climatological Association. What a great name.
Yeah, I don't know that one.
It's the oldest medical society in America, and it's got the name climatological because, as you will recall, things like asthma and tuberculosis were due to
Yeah.
climate and clean air and all that kind of stuff. So you get elected to this. They elect about 20 physicians a year, and you would know about half the members. And it's assisted living for very older, smart physicians. That's the way I would describe it. And to a person, 100% of them would mirror exactly what I'm saying. But to some extent, they're at the end of they're at the end of the sliding pond. I mean, many of them are still in leadership positions, but many of them are retired, and they just sit around bemoaning what's going on. But I do think that patients are making clear what they want, and I think that paradoxically, some of the things that I'm espousing actually would turn out to be financially better for hospitals than they imagine. But it's very tricky because we've given all of this leadership up to us. I mean, if you look at the growth industry of medicine, the thing that's grown the fastest by a factor of 5 to 1 isn't physicians, but it's administrators in hospitals.
Yep. I
And
fear that you are correct.
no, I know I'm correct. And in that setting, They basically perpetuate themselves by
We're,
making.
we're losing your picture, Mark.
Oh, I'm sorry. I'm sorry. Excuse
there
me.
you go. There you go.
I sat back slightly. They basically perpetuate themselves by by making endless demands and things without, in fact, understanding what the impact has on people. I mean, my patients actually, after a while, when you have relationships with them, in many situations, take up much less time.
It's
I mean,
about this time in the broadcast that I ask Andrew to ask a question. And one of the things I'm going to ask him to ask a question about is AI, because he is a pretty knowledgeable guy when it comes to AI, working for Microsoft and delving deeply into it. So what strikes you about this kind of discussion, Andrew?
Well, it just, obviously I hear a lot of issues with the healthcare system. It's been pushed by many different aspects and technology. Um, have you seen the implementations of AI actually help with the delivery of care, or has it more impeded it and made it less human and more on the error side of what you were describing?
I'm not sure that I can give you a perfect answer because I don't necessarily understand how I would use. I think AI isn't a term I necessarily use correctly. I don't think computer assisted diagnosis when you're reading x-rays, I don't know that I should be calling that artificial intelligence. But
Well,
if
it
it
is. I
is,
mean, that's one of for example, reading a mammogram, having a computer read a mammogram is one of the things people talk about a lot.
but okay, no, I understand that. I'll come back to that because I know a lot about that. But I don't know that I was thinking that was AI, where in the process it's reading new literature and looking up other things. But certainly, computer assisted diagnosis is incredibly fabulous. I mean, the technology of medicine is not to be sneezed at. I'm not trying to make any comment that sounds anti-science about this. And I have a completely open mind to how much additional diagnostic potential can be brought to play. For example, assuming the data in a chart are reliable, which is where I just got through telling you an anecdote that they're not, but assuming you're feeding into a computer a vast array of laboratory findings and physical findings, and the computer says, "Well, you really haven't thought of the possibility that this is some rickettsial disease or something." I mean, that's fabulous. I mean, how could you, the notion that that something can bring, I mean, no one can keep right now electronic records, after I've gotten through bitching about them, aren't used appropriately in terms of AI. Most patients I see are on half a dozen medications. No one can keep track of which ones affect which others and which ones cause which toxicities. It's just impossible to do that because they're just complicated. The drugs are changing all the time and they all interact with your GFR and your pulmonary functions and everything else. But EMRs don't do that right now. They just get pissed at you that you haven't checked the medication record when you see a patient and checked off that they had aspirin 3 years ago. But it's not telling you anything that's formally getting better. So to get to your question, Andrew, I think that there's extremely great potential for science to improve and avoid errors. My goodness, yes. My goodness, yes. I think the era of just holding an X-ray up to saying, "Oh, that's what I see," is should be over as quickly as possible, as quickly as possible.
How do
But
you
that's
how do you use it now with mammograms? Are your patients getting that?
all of our mammograms are overread by computer assisted. And having been involved with, I don't know how many tens of thousands of mammograms, and even in part actually have been involved in the medical legal profession. When you see cases, the most common medical malpractice case in the United States is still failure to diagnose breast cancer. And a lot of them based on misreading mammograms. And when you look at mammograms, what you see is it's not like, "Oh, I just can't quite figure this out. You see this little bit of line here? Do you think that's serious?" Those kinds of things never, in my experience, will result in medical error. Where you see the medical error is you look at the mammogram a year later when someone is suing, they say, what was he doing eating a corned beef sandwich? How could he not see this gigantic thing in the middle of this film? And that's where these computer overreads are perfect. You never make those mistakes because the thing doesn't get tired. The thing doesn't sit there, having a Diet Coke while it's looking at the films.
So, as we wrap this up a little bit, because I think we've covered everything that we discussed that we wanted to cover. The question is for both the patients and the doctors, what is the baby step we can take today that might, I mean, one of the things I'd like to see, and well, I see it because I have a concierge doc, is having someone I can call when I need a doctor.
Well, I think this could be studied. I think you could have demonstration project. You could take half of your oncology service and say, we're going to redo this entirely in a patient-centric fashion. And at the end of the day, see, did it cost you money by saying, okay, take as much time as you want. We're going to cut down the number of patients you see. We're not going to allow, see what happens and look at outcomes. Look at outcomes. Because there is no question in my mind that, well, maybe that's a bit arrogant, but I think that if you did such a thing, you'd find that many of these aren't simply just time consuming, but are actually eventually wind up in being very productive in terms of actually the financial care of taking care of patients. And the satisfaction will go up enormously.
I agree. I agree. Anything else you want to get out there that's on your mind today?
Well, I'd like to just spend one more minute, if you're willing to,
Sure.
about the notion of burnout. It is
Yes, please.
It is very clear that many, many physicians are endlessly dissatisfied. And if you're pissed off and don't want to do it, and you're going to either retire or start a business, like you're just going to give Botox injections, or you're going to quit, or get depressed. Suicide rates are very high amongst physicians, and so is depression, and so is substance abuse, alcohol, and other kinds of stuff. And I think that's so tragic because most people, I think, still go into medicine because they have some urge to do well, for it to be a profession in which you take pride. You're not in what you're doing. And I feel that we owe it to our colleagues to keep ranting about this stuff.
Yeah.
But I don't think you could just say it's an old guy, which I am, carrying on this way. But I do think that there are tangible and measurable benefits that would be seen, and this could be done in a controlled setting. This could be done in a control. Some of the institutions that are much flatter in terms of their organizational structure and run by physicians actually do this a lot better. Mayo Clinic does this a whole lot better. Cleveland Clinic does this a whole lot better than many other hospitals because they are physician-led. And I think that makes a big difference. And I think we've given that up. I think we have a bunch of people telling us what to do who don't know their body parts from their elbows.
And there, folks, is my friend Mark Lipman in the flesh. I can't thank you enough, Mark, for taking the time to talk to us. We will tell you when this is going to be posted, which Andrew decides. I don't know how soon he's going to post. It's usually a Thursday, but it won't be next Thursday, that's for sure, because that's Thanksgiving. Probably be the first week in December. Is that right, Andrew?
Yeah.
Yeah, probably the first week in. I will send something to you so you'll know.
Well, I appreciate you allowing me to get this off my chest, and I hope your program is very successful. The ones
Thank you.
I've heard are really great.
Thank
All right, take
Thank
care.
you so much.
Thanks.